Hello, and welcome to today's webinar, Hope, Transformation, and Post-Traumatic Growth. I'm Alyssa Curtis, and I will be the moderator for this webinar, presented by the National Healthcare for the Homeless Council and the Coldspring Center for Social and Health Innovation, with support from the Health Resources and Services Administration, Office of National Assistance in Special Populations. This session is being recorded. This is a 90-minute presentation with the last 30 minutes reserved for Q&A. There's a chat box below the presentation slides for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end of the presentation along with the Q&A session. Remaining questions will be logged and provided to the presenter for written responses after the webinar. If you're having technical issues, you may also call the Council's office at 615-226-2292 and speak with Lori Hopper. Our presenter today is Matt Bennett, Chief Innovation Officer at the Coldspring Center for Social and Health Innovation. Matt specializes in the development of trauma-informed care, quality improvement, and results-based leadership in clinical practices. As a dynamic trainer, Matt's expertise has taken him around the country speaking on topics such as trauma, leadership, quality improvement, motivational interviewing, and resiliency. Thank you, and now we'll turn it over to Matt.
Thank you very much. Welcome back, everybody. We're now on our fourth and final webinar, and want to thank you for joining. If you haven't been to the first three, I know they will be on the Council's website, and I think everybody on the call that's been registered will get a heads up on that piece as well. So today we're going to continue with these overarching goals that we set at the first of our series, and that's really to continue our understanding of how trauma and neurobiology really helps us have a deeper understanding of homelessness. And today we get to have fun because we're talking about the healing process and how post-traumatic growth plays a really key role in helping people get back control of their lives. And again, I know for so many of you, a big part of that equation is really helping people establish permanent housing, helping people engage and remain retained in healthcare services, and really start to integrate themselves back in many ways into the life that they want to live for themselves. Again, really utilizing the knowledge to start to address some of the needs we really, as we talked about last week with addiction, stress, the neurobiological impact of medical impact, psychological impact of trauma. It's a pretty dark place where we meet a lot of our folks. But as we'll see today, there's really hope for everybody and how we can utilize this to help people on their own journey. I hope to continue the theme that we've had throughout our time together as well, as hopefully some of the material we cover today will help inform your own advocacy around this issue. This research has really helped me really frame what folks need to overcome obstacles like homelessness, addiction, and again, really become that immaculate, tax-paying citizen or whatever we want to put that goal that society has for folks. But really looking at this as part of our advocacy, as we know what people need to really heal and grow, and the better we can communicate the why and the science behind that, the better able we are to help our communities change their perception of folks struggling with some of these issues. We are at the final one. I am kind of sad for this. I've really enjoyed these. I may show up at 1 o'clock next Wednesday anyway and just talk to myself. But today's the final day. Again, if you missed any along these lines, I know that they'll be available for folks to see. I hope also and encourage you, if you've liked what you've heard throughout the series, again, they're going to be recorded. So you can share these with your coworkers and other things as well, as hopefully they can be a tool well beyond our time together here today. So just some objectives that we have for the time together today is really look at how to utilize the drivers as successful outcomes to build relationships, establish hope. One of my goals really of today is we know what our folks need. And the real cool thing about the research is we've kind of always known this, and we have the ability to do this. Now, a lot of us will have a challenge, and I just want to put it out there because I'm a realist. We'll have a challenge as we don't necessarily have the capacity. Our funding doesn't really maybe allow us the flexibility to do some of this stuff, even if the things that we need to do, at least initially for recovery, are fairly simple. Look at some of the cool science behind the neuroplasticity and transformation. Again, we've left you in a pretty dark place last week with the neurobiology and biology of addiction, of trauma, and now we're going to look at how we can utilize the science to help in the healing process as well. And again, how we can help be a partner in that post-traumatic growth process. So where I left you off last week was I briefly introduced the hero's journey, and I want to go into a little bit more detail on my thinking around the hero's journey, because this came out of a struggle that I was having in my in-person trainings. Is I was doing this activity where I had people, it was a small group activity, think about the words trauma victim, and what role does trauma play in the victim's life? And I always had to explain, and if you have to explain an activity too much, it's not a good activity, but I always had to explain that anybody that's experienced trauma has been a victim of trauma. Again, if trauma is something you can just shake off, we just call that stress. But trauma, something more powerful than us, whether that's somebody or something, or an accident or something like that, has at least for a short period of time really pushed us down and kept us down. And so I wanted them to think about the role that trauma plays in the victim's life. And most people would say that the trauma is bigger than the person. The trauma is holding the person down, that they're not able just to recover from it, that they're sort of trapped by it. And then I asked people to flip and think about the words trauma survivor, and what's the role trauma plays in the survivor's life. And people started to see that as we become a survivor and we have that mindset, we start to have some control over what's happened to us. So we're able to get back up. We start to gain strength. And the reason why I did this exercise is that thinking is so important, and I still think it is very important, and helping people see themselves not as victims, but having control over their own recovery process. But my struggle was that survivor didn't really capture it. I wasn't in love with the word. I got my point across with the small group activity, but it just wasn't enough. And around this time, I was listening to the lectures of Joseph Campbell. And if you're not familiar, Joseph Campbell was an expert on mythology and created what he called the monomyth, or the hero's journey. And he studied mythology across different cultures, and he found that there was this story that was inherent to really all of us as human beings, that no matter what culture he was studying, that there was a common hero's journey, whether this was a mythological character, a story about an actual person, a religious figure, is that, and this is what we cover for the most part, is that trauma thrusts the hero from sort of the light and well-being of a normal life into the darkness. And there's suffering, there's challenges, as we talked about, there's addiction, homelessness, all these medical things that we're seeing coming when we talk about trauma being the public health issue of our times, all these devastating results. And for so many of our folks, unfortunately, they end up in that abyss of spiritual and emotional death. And as I kept listening, and Spotify had like 40 hours of Joseph Campbell's lectures, and yes, I did listen to all 40 hours. And I'll always remember this, because if you're listening to Joseph Campbell's lectures, you might as well clean the house. It makes your wife happy, and it's better than sitting around doing nothing and listening to Joseph Campbell. So I was vacuuming the dining room. I'll never forget this. I was just vacuuming, listening to Joseph Campbell talk about the hero's journey for the 1,000th time. And it really struck me is that he was also talking about so many of the folks that I worked with. the hero struggles were really the struggles of my clients, the kids, the families, the adults that I had worked with. Because of no fault of their own, they were thrust into this darkness, and the challenges that they faced were really things that would overwhelm even the strongest person. And so many of them found themselves in this abyss. And it just kind of really opened my eyes to the real intensity of the struggle, and why hero fits for me so much more than survivor does is there's just this group of folks who not only survive this experience, but come out of it with a huge amount of strength. And again, in the HCH environment, I know we all know these folks, and we're lucky enough. I know I've probably got a few on the call right now, but we're all lucky enough to know some of these people in our own work. So what Joseph Campbell found throughout with all these heroes, these religious figures, really the most powerful men and women throughout history, is in their darkest moment, somebody comes along and helps. Somebody finds the person that's lost in that abyss. And, you know, to me, all of a sudden, outreach just hit me. Also, with folks doing case management and therapy and medical profession, is even if you're not going out onto the street to find somebody, you sort of find the person buried under all those labels. And so it was really powerful to say, okay, even Hercules, even all these great, powerful people needed somebody at their hardest moment to come along and sort of show them the light of hope. And so we'll talk about the power of hope as really that spark to the transformational process that eventually leads to post-traumatic growth, and then a return back into normal life. There was a great question last week of, well, is this the same normal life that they left? And I thought that was a great point, because it's really not. It's a new life would probably be better than normal life, because you can't go through this journey without being transformed by it. And the goal is to really make that transformation a positive one, and again, to gain strength and wisdom from the experience. And so this will give us an outline as we shift to this other side, going to hope, transformation, and post-traumatic growth. One quote that I use is from a Buddhist monk, and this is really my definition of trauma-informed care, but I think it really sets up this section really well. And he's talking about Buddha here. I'm talking about you. So don't get stuck up that I use Buddha here. Basically, we can replace that with case manager, nurse, front desk person, really you, because this is the best definition of trauma-informed care I've ever found, even though it wasn't necessarily his intent to give me a definition of trauma-informed care. But I just think this is beautifully sums up what we're going to be talking about today. He says, when I was a novice, I could not understand why, if the world is filled with suffering, the Buddha has such a beautiful smile. Why isn't he disturbed by all the suffering? Later, I discovered that the Buddha has enough understanding, calm, and strength. That's why the suffering doesn't overwhelm him. Again, when we talk about trauma-informed care, hopefully after this 4-part series, you have a deeper understanding of the folks that you're working with and the impact of trauma. And also there's that strength, that calm and strength there as well. That really, to me, speaks to the importance of our own self-care. I always like to stick a reminder of self-care whenever I can. He is able to smile to suffering because he knows how to take care of it, and this is what I love, help transform it. That's that transformational process. And again, something about us as human beings, which I think is really beautiful, not in any way to say that we're weak as a species, is that we need other people in the recovery and growth process. And that's for everybody on this call. If a severe trauma would happen to any of us, we need other people to fully recover from it. And so we are part of that transformational process. And I think we're just so lucky to spend our professional lives in that work. And it just really gives me a way to frame it in a very powerful way. We need to be aware of the suffering, but retain our clarity, calmness, and strength so that we can help transform the situation. The ocean of tears cannot drown us out if our karuna or compassion is there. That's why the Buddhist smile is possible. Again, just I think something to really set up the material that we're going to cover in the short time we have together. So post-traumatic recovery, and this is really, to me, sort of the spark of where the growth process and transformation happens. And it's really recognizing that there is a better future. And I think I'm talking to people that understand this. As somebody who's experienced chronic homelessness or addiction over decades, that just becomes their reality. There's not like, oh, I'm choosing this over this alternative reality. When we're stuck in that survival mode, we're not thinking 5 years in the future. We're thinking about the next moment and how do we keep ourselves safe now. So hope is that change is possible, and also I put self-confidence on there as well, that change is possible and that the patient or client can contribute in making it happen. So those two work together in a very powerful way. Recovery is determined also by a mix of psychosocial support, resources, and motivation. We know, and I've mentioned this already, but I just want to reinforce it, that resources are not enough. Now, if we don't have resources, that's obviously a problem as well. If there's not enough housing, if there's not enough mental health services, substance abuse services, medical services available, obviously that's a problem. But, you know, most people on the phone, I believe, have had an experience, whether in HIV, we have medication, but we don't have everybody with that viral suppression. We may have housing programs, but not everybody are sort of ready to move into those. They may feel more comfortable right now living in the shelter or even living out on the street. And so what we know is a resource in and of itself is not enough for most people. We also have to couple that with supportive services as well. So those two things work together. And once we have that mix of support, resources, what we see is motivation for this journey. Again, if we can't see a better future, there's going to be little motivation. If we don't have support, especially if we're in that abyss, it's going to be hard for us to see hope. And the resources, to me, help make the hope concrete. Here is an apartment. You could have an apartment like this someday. Oh, there is a way to feel better if you're adherent to your medication. Those sort of things can be very, very powerful for the individual. Post-traumatic growth, on the other hand, is really when the traumatic event starts to be seen as an opportunity for growth. I wish, and I think I've shared that I've struggled with my own trauma from childhood at times in my life and growing up. And I wish somebody would just came along at one point and said, you know, Matt, I know it really sucks right now. This is terrible, and I'm sorry you're going through this. But if you're able to overcome this pain and suffering, you're going to build up a resiliency that you can use throughout the rest of your life. I just wish somebody would have said that simple statement to me, is that this suffering in a context can actually be the ability to get strength and to get wisdom. And I think our folks need to be reminded of that as well, is that, you know, all this that you have been through, it really does suck. And yet, if we can work together and overcome it, it can actually be a source of strength. And again, what we know is when people experience post-traumatic growth, they can bring that resiliency and that robustness, that energy into other parts of their life, and we actually can build up resiliency over time. This is why folks that have experienced homelessness that are now either a provider or an advocate in the HCH community, some of the strongest people that I've ever met. You know, and I just love spending time with these folks because you can just kind of feel their strength and wisdom from that experience, and they speak from a place of such strength and courage. So what helps to do this? If recovery and growth are our goals, what are some aspects that really help us to facilitate this transformational process? And one of the real goals of this is to shift this personal narrative. As we talked about last week, trauma is that narrative thief. It steals a positive view of self, the world, and relationships. And so what we want to help do is to reset that. And so we'll look at ways here that we know best practices to help reset that narrative and help people, again, start to see themselves in their lives in a more positive approach. So most of you have probably seen this study at one point or another. This has been around social services, psychology, social work for several decades now, and relative or related studies have been done in medical care as well, again, with maybe a little different outcomes, but this is a pretty standardized thing that we see in the field of the helping professions. And so we know what determines successful client outcomes, whether those outcomes are medical outcomes, whether they're social outcomes, housing outcomes, whatever those might be. The first, and this accounts for 40% of the pie, is what the client walks through the door with. And I used to not spend a whole lot of time on this as, you know, really this is just, this is the reality. And, you know, when I thought about that, our folks come in, homelessness is probably not the only issue that they're facing. A lot of them are struggling to manage chronic diseases. We've talked about addiction, histories of trauma, and we can start to add up those labels. Their mental health diagnoses, all these different things come through the door. But they also, what I realized is within this 40%, there are a lot of challenges. But there's also a lot of strength that walks through the door with them. And this is where that strength-based approach, I think, is so critically important, is we can focus, and sometimes we have to focus on those presenting problems, but we also have to spend as much time, if not more, really digging for those strengths as well. If they've been surviving out on the street, they have a huge amount of resiliency and strength that they're walking through the door with. So even with that, we can have a big impact. The great thing is, even if we account for that, that's just what walks through the door and we have no control of that, the client characteristics only determine 40% of the overall outcomes. The other 60% is really what we create, and we have a huge influence on whether or not these are successful. 30% is the quality of the relationship, and we'll talk about why that's so important as we move forward. 15% is hope, and 15% are the techniques that we use, the best practices. And so we're going to break down these and look at them in more detail. I love this. I used a quote from Judith Herman last week. This is the positive end of this. And this is one of the most beautiful quotes I found in the trauma literature. She says, recovery can take place only within the context of relationships. It cannot occur in isolation. In her renewed connection to other people, the survivor recreates the psychological faculties that were damaged or deformed by the traumatic experience. The beautiful thing, and I appreciate this so much, is that a lot of times, and as we talked about, a lot of the trauma our folks experience is interpersonal trauma. Someone abuses them, neglects them. They've experienced interpersonal violence in their life. And so we've seen it, and I know as HCH providers, you bear witness to the impact of that trauma and what one human being can do to another. But that's also how we heal as well. We're incredibly social beings. And when we sort of think about how we heal, I like to show this video here, and it's just been a really good visual representation of how I see a trauma-informed relationship happening. So I'm going to play this here, and these pendulums should continue the beat that they're originally put at, so they should stay right where they're at now. Now we know that the cans down here help speed up the process, but this would happen even if it was on the table as well. I like to think about the cans. Empathy and compassion kind of speeds up the process. But watch what happens over time. And I love the sound, how the sound changes over time. I like to think that we're that middle one, and this is our caseload that we see. As you see over time, things that are in proximity with each other start to vibrate in sync with one another. And I like to, you can't see me, but move my arms back and forth in this way. And this synchronization is so critical to the overall healing process. And so just something that I really like to visually represent what I see and what we're looking to establish within that trauma-informed relationship. So when we talk about this and how do we establish relationships, it really leads us into the concept of both trust and safety. And so when we look at trust, these are really those foundational pieces. We could talk I could talk literally for a day or two on the trauma-informed relationships. But these are the two things that with brief time, I think it's important for us to focus on. I define trust as the assured reliance on the character, ability, and strength of the helper. And so we, in many ways, have to bring that strength. Our clients can really sense if something's not right with us, if we're burned out, if we're worried about something else, if we're not paying attention. They have survived on the street a lot of times by reading other people. And so the trust is really built on who we are as much as what we do. And I think that's important for us to remember. Again, this is my shameless plug for you to take care of yourself and practice self-care, is that we have to really bring a strength of character to our work every day. If they don't feel like we're strong enough to hear and be exposed to their suffering, they're probably not going to feel comfortable sharing it with us. And so there is that piece that we bring to the table. And what trust does is it really increases the likelihood for folks to function back inside that window of tolerance, which we introduced in an earlier training. When we're sitting with somebody that we trust, we release this chemical called oxytocin. And oxytocin has just, I see it more and more as that foundational chemical to healing, recovery, and transformation. Again, we know clearly from a lot of different studies that the relationship is a huge predictor of overall success, that the quality of the relationship is so key. And what the relationship, again, biologically creates is this sense of oxytocin, this oxytocin release that makes us feel connected to another person. When we looked at those metrodomes and that synchronization that happens when things that are in proximity kind of vibrate with each other, if I walk in and my life's just a mess, but I walk in and you're solid, you're regulated, you seem to have the strength to listen to me. Over time, and for some of our folks, over time may mean several months, if not even longer, I will learn that you're strong enough to earn my trust, that you're somebody who's not going to judge me. And over time, that chemical, oxytocin, is present more and more. Unfortunately, for most of our folks, when they walk through our door, it's not the oxytocin they're releasing. It's a chemical called dihydrotestosterone, or DHT. And DHT is basically released when we're unsure about somebody or we don't feel safe, and we'll talk more about safety here in a second. And so if you think about so many of the folks, when they walk into our clinic or our organization for the first time, they're not only carrying baggage of past trauma and hurt that other people have inflicted on them, they're also carrying a lot of pain from being led down by the quote-unquote systems that are designed to supposedly help them. I always ask the question in my training is, how many folks would say that the majority of people on their caseload have actually been abused by the quote-unquote system? And pretty much every hand goes up at every training. And so they're walking through our doors with all this collective negative experience about relationships. They have that DHT, and if I have that DHT, I'm much more likely to trigger something in the environment to trigger either a re-traumatization or that amygdala fight or flight response. So again, as we build a relationship over time, we start to replace the DHT with oxytocin, and then we'll talk about how that is a powerful chemical when we talk about the hope in the transformational process. Trust is also critical because it leads to psychological safety, and safety is big on two ways. One is that if safety is not present, we can think, we'll talk about both physical and psychological safety, but if I don't have basic safety in my life, if I don't feel like I have a safe place to sleep, if I don't feel like I have a stable source for food, all my attention is going to be creating safety in my life. So where's the safest place I can sleep? Where can I get some food so I can at least get some substance in my body? I'm not sort of thinking about anything out and beyond that. So the more that we can increase safety, the more likely, again, we're able to get that engagement. physical safety is key, but also psychological safety is becoming more and more of a key aspect of trauma-informed care. And psychological safety is really, to me, is based on that foundation of trust, where if I disclose something to you, I know that you're not going to judge me. You're not going to put me down. That I feel safe being who I am with you. And I think that we don't pay attention to that sometimes enough, that powerful role that we play, especially with the stigma around homelessness, addiction, HIV, all these things that our folks walk through with, is that for a lot of them, a case manager, a front desk person, a nurse, a therapist is really the only person in their life that they can be real with, that they can be themselves with. And so that safety allows us to take risks, and not risks like going skydiving or something like that, but risks to say, okay, I might try a day of sobriety, or okay, I've had bad experience in housing programs, but you seem to like this one, and I really want to get out of the shelter system. I'll take a chance. Those are the type of risks where we have psychological safety with somebody, we're more likely to consider and act on those risks. So what we want to do on this foundation of this strong relationship is to really then help see that there's a better life for the future. And one of the things that we know about hope that really helped my understanding about it is it's a lot like the placebo effect. And basically the placebo effect and hope, both are similar because you think the future is going to be better than the present. So most of us understand the placebo effect. A doctor asks you a whole bunch of fancy doctor-like questions, gives you a diagnosis, and hands you a pill. You think that it's an actual pill that's going to treat your symptoms, but it's actually a sugar pill. And that sugar pill actually, as we all know, is really a miracle of medicine. Everything that's on all those awful commercials that we have to watch on TV all the time, really just you see that those things have to outperform the placebo effect. And a lot of them don't outperform it substantially. Some only, you look at those little tiny prints as they're going through all the god-awful side effects, and some of them only outperform it by 15, 20%. And at this point, the little sugar pill has very few side effects. And so really what we do is we see the same chemical release from hope, because again, I think that things are going to get better. So, and again, just like with the relational piece of things, we see some of these chemicals prop back up that we saw last week with the addiction. One is the endorphin release. And again, we talked about that. Reduces pain, relaxes muscle, improves immune functioning. So again, if I take a sugar pill, my immune system is actually going to be activated, and in many ways that can fight off the disease. And the other hand, it helps make me feel better. It takes away some pain, so it's also addressing the symptoms as well. When we feel hope, we also release the endorphins as well. What we know with also when we experience this, we release that dopamine, which we also talked about last week, and serotonin. This just gives us a sense of well-being and happiness. So I'm a guy who, if I'm having, I get some antibiotics because I've been sick for that 3 weeks and I just feel miserable. I want to get that pill in my system as quickly as possible. I don't leave the doctor's office without taking that pill. Literally in my health clinic, there's a drinking fountain right next to the pharmacy. I get my pill, I open the thing, I pop it in my mouth, and I take a drink of water. I want that antibiotic in my system as soon as possible. And even though it's going to take a while to take effect, I start to feel better right away, and I'm all for the placebo effect in my own life. So we also release this dopamine and serotonin. So again, when we're thinking about that better future, we're releasing some of those chemicals similar to what's released in the addiction process as we talked about. But these, again, are having a positive impact on our biology. Now, here's the really cool piece of information. It starts to explain why the relationship is such a powerful thing with that release of oxytocin. So let's think about this from the placebo perspective. If I'm two different options. You come into a doctor's office, you get diagnosed, you get a prescription, has a name you can't pronounce on the medication, you take the pill. The likelihood is that you're going to trust the medical provider and their advice. And if I trust my medical provider, again, what we talked about is I'll also release oxytocin. So what oxytocin does is that it allows those dopamine receptors, and to a little lesser extent, the endorphin receptors, and to a little lesser extent the dopamine receptors, to be more sensitive. In other words, the endorphins will have a bigger influence on how we experience. Again, it's going to kill more pain. It's going to make us feel better. So if you think about this from the other perspective, if I just come up to you on the street one day, it doesn't look like I've showered or shaved for about 2 weeks, and I hand you the exact same sugar pill, and I say, hey, take this, it's going to make you feel better, and for some reason you end up taking it, but you don't really trust who's giving it to you, it's not going to have that much of a placebo effect. Again, because that trust isn't there. So now let's flip this into the work that we do. If we have the time, and we, again, have our own resiliency, robustness to really work through and establish a solid relationship, we create that biology that's releasing oxytocin. Then when somebody talks about a better future, there again, that endorphin release that's associated with hope and talking about, yeah, I could be permanently housed. I could eventually get back into the workforce. I could get my kids back from social services. It releases those good chemicals, and if I'm with someone I trust, that's going to be experienced more powerfully, and actually what we know is then that increases the level of motivation to take action towards that better future. So just some really cool science coming out of the biology piece here. So there's the relationship, the hope. The other 15% is techniques, and sometimes this study is made to make people like me who spent tens of thousands of dollars on a graduate and undergraduate degree in psychology feel bad about ourselves because, oh, you went to all this school and you only get a 15% boost of your outcomes. Well, yeah, that doesn't make me feel bad because I'm in a lot of student debt, but at the same time, what we know with these evolving best practices is something like motivational interviewing. Spends a lot of time talking about building a relationship through those ORs, those open-ended questions, affirmations, reflections, summaries, the spirit of MI, all these things creating partnership, the guiding style of communication. All these things are designed to build the relationship, to really establish hope. So what we see now that we're in the era of best practice, treatment models like motivational interviewing is that not only are they a best practice technique, but they also encompass the whole of this 60% there too. So again, I think this is, that 15% could be the determining factor, and this is why I think we see the power of motivational interviewing that's so relative to a lot of our environments. So let's talk about the journey to post-traumatic growth. But before we do, I actually do want to make one more point on this. I apologize. Is that when we talk about what we can do to improve outcomes based on this, and this is one of my frustration with some of our current funding and how we approach care and services is, if you were to ask me, okay, what is one thing I could do to improve the overall outcomes of my patients or clients? My easy answer would be to give folks more time to create healthy working relationships. My second quick answer would be to train them in motivational interviewing so they can maximize the hope and technique part as well. But the one thing I would do is for physicians, for nurses, for case managers, for therapists to have more time, because that relationship, it's not like somebody walks in and is just going to trust us right away. And so I put this out here because when we think about our own advocacy, the answer is kind of simple. We have it right here. It's well established, is that the relationship is going to improve the outcomes. But from a realistic perspective, I know that very few of you on this call, if we did a survey, would say, you know, I have all the time I need to give my patients or my clients everything they need from a social and relationship perspective. That's an answer I hardly ever hear in my travels across the country. So again, I think it shows how simple improving services are on one hand, but again, how hard it is under some of our current funding structures. So again, now as we move to this post-traumatic growth, I want to walk through this model. And to be very clear, this is a very generalized model. Everybody walking through your door has had a different life experience. They've had different trauma. They've been impacted by homelessness, addiction, domestic violence, all these things in different ways. And so just like everybody's experience of the world is different, of relationships is different, their struggles are different, their journey to post-traumatic growth will be different as well. So this is just sort of an overarching model of what things and steps that most people go through as part of their healing process. And so I just want to be very clear, this is going to be individualized, but I just kind of want to go over some of the key steps that most people go through. So I want to play this other video on neuroplasticity as well, because when we talk about the post-traumatic growth process, what we're really talking about is changing the physical structure of the brain. And as we look at the video, it really, to me, this is where hope really exists for everybody, is no matter how much you've gone through, you can really change your brain if the right mix of resources, support come into play. So this just sums it up pretty quickly, and it has some pretty cool graphics that I don't.
Not so long ago, many scientists believed that the brain did not change after childhood, that it was hardwired and fixed by the time we became adults. But recent advances in only the last decade now tell us that this is simply not true. The brain can and does change throughout our lives. It is adaptable, like plastic. Hence, neuroscientists call this neuroplasticity. How does neuroplasticity work? If you think of your brain as a dynamic, connected power grid, there are billions of pathways or roads lighting up every time you think, feel, or do something. Some of these roads are well-travelled. These are our habits, our established ways of thinking, feeling, and doing. Every time we think in a certain way, practice a particular task, or feel a specific emotion, we strengthen this road. It becomes easier for our brains to travel this pathway. Say we think about something differently, learn a new task, or choose a different emotion. We start carving out a new road. If we keep travelling that road, our brains begin to use this pathway more, and this new way of thinking, feeling, or doing becomes second nature. The old pathway gets used less and weakens. This process of rewiring your brain by forming new connections and weakening old ones is neuroplasticity in action. The good news is that we all have the ability to learn and change by rewiring our brains. If you have ever changed a bad habit or thought about something differently, you have carved a new pathway in your brain and experienced neuroplasticity firsthand. With repeated and directed attention towards your desired change, you can rewire your brain.
So again, there's really where that hope lies, is that whether we're talking about a behavioral change, whether we're talking about a healing process, out our lifespan is highly plastic, and we can really heal from even the worst experiences. And so let's look, especially from the healing and growth recovery process around trauma, what are some things that are necessary? And the first step of the journey is really the ability to gain some internal emotional regulation. Again, this helps, as we talked about that window of tolerance, how we can process things through the cortex and the prefrontal cortex versus that amygdala fight or flight, that hyper-aroused mentality. And again, safety's here as well. As a therapist, if somebody comes into my office and they're struggling with housing instability, food instability, the first thing that I would work in, I would not have any therapeutic approach at that point. I would work on helping, I basically become a case manager. I try to connect them with housing services before I would start to do much of any therapeutic work. So without safety, healing and recovery are going to be very unlikely. So that's going to be, again, a key fundamental point throughout this journey. And we all, whether you're in a therapy role, whether you're in a medical role, a social support role, we all play such a critical role because some people will tell a case manager or a physician or a nurse or the front desk person something they may not tell me as the therapist, even though we assume that I know more than maybe anybody else does. Sometimes that trust is built up more in other places. So again, everybody focusing always on that safety piece. Awareness of management of those arousal states, that fight, flight, the chaos, the rigidity that we've talked about. And this takes several different forms. From everybody's perspective, I think there's a key piece of feedback, especially when we see some escalated behaviors happening. One of the things, and again, I'm very much a realist with everything I approach, is I'm somebody that has had to kick a lot of people out of my programs over the years because they made the overall environment unsafe for other clients and patients. And when I say those words, faces pop up, and they still sort of haunt me in a hard way because, you know, I really, it breaks my heart that we had to do that. And one of the things that we want to try to do as much as possible is hang in there through the ups and downs. But again, I'm a realist, and I know that can be a struggle sometimes because we're trying to manage overall safety within the environment as well. But when really escalated behaviors do happen, whether we can retain the person in our services or unfortunately not, one of the key, I believe, and what I've seen is it opens an opportunity for insight. And no matter what role you're in, saying something like, you know, when this happened, this is how it impacted us, that we didn't feel safe, that we were worried about you and we were worried about the other clients as well. If we check back in, we can find out some real fascinating things. One of the things is they may not remember anything about the event. They may have disassociated during the experience. They may have not seen it nearly as escalated as we do. Again, it may not always seem like we're getting a logical response. They may have seen it very differently. The key thing is so many times our folks have had behaviors and nobody's ever connected with them to talk about the impact that their behaviors are having. So everybody can do some role with this. The other thing that also is now getting more and more into our lexicon and our practice is the practice of mindfulness. If you've never heard of mindfulness, do me a favor and Google it. I could do a whole half day on mindfulness at this point, but what mindfulness does is that we know it increases the flow of blood to the prefrontal cortex. It builds the parts of the brain that help us emotionally regulate. So when we do things like deep breathing with clients, even things like therapeutic yoga, all these different coping skills and trauma treatments that are coming up around mindfulness, we're building the capacity for them to not only be more regulated, but also be more aware of how stress is impacting their lives. Now, from a therapist perspective, and I'm going to kind of mention, when I say from a therapist perspective, it's a real caution that if you're not doing therapy, be very cautious with doing any of this. Though I know a lot of our folks aren't engaged in therapy, and that makes this kind of tough. But from a therapist perspective, what I would also start to look at is connecting and bringing awareness that some of their current behavioral struggles are actually related to their past trauma. And so I want to do this in a safe way once we build that safety and trust, but really helping them create that insight as well. Then what we do, again, and this happens mostly in mental health services, is we start to work through traumatic memories. There's been some really amazing research on the power of memories, especially traumatic memories that lead to post-traumatic stress disorder, that re-traumatization that we've talked about. We know that when we recall a memory, we destabilize it for a moment. It's a really cool piece of science. So usually when somebody with post-traumatic stress disorder or a history of trauma recalls the traumatic event, it triggers that fight, flight, freeze reaction. That is the normal PTSD sort of response, when the memory sort of has control over us and sort of takes over. So in the evolving best practices in trauma treatment, what happens is I'm going to spend a lot of time creating a safe environment. We're going to build up trust. We're going to build up that psychological safety. I'm also going to have you practice mindful techniques or coping skills, deep breathing, both within the session but also give you some homework as well. And over time, what I want to help create is both relationally, so I can help you create that safety, and over time, whether it's the eye movement therapy, EMDR, this also is used in a lot of the cognitive behavioral approaches, is that I'm going to get you in a very calm place, a very regulated place, well within your window of tolerance, and then I'm going to ask you to recall your traumatic memory. And so what happens is, instead of the kind of the freak out trauma reaction, because I'm in such a regulated place and state to begin with, instead of triggering the PTSD reaction, I'm able to keep myself in my window of tolerance. And so when that memory sort of gets locked back in after being destabilized for a brief moment, it takes a little bit of the emotional power away from it. Because instead, again, the reaction, I surrounded it with calm. And this sometimes happens over months or more of really starting to take the power away from these memories. We're also knowing things like with the EMDR, following a therapist eye back and forth. There's the tapping. When we activate, this is activating parts of the brain that are shown to speed up or help facilitate this process as well. So we're seeing some really amazing things coming out of therapy. Again, this is really intense work, and I highly suggest, again, this is where mental health services come into play greatly. If you're a case manager or a nurse that aren't really in that role as therapists, be very cautious about doing this kind of work unless you go get some real specific training around it. Even therapists are real cautious about this and spend a lot of time really building that trust first. Then there's the integration. Once we gain some of the emotional regulation, as we start to take feeling less of a victim to trauma, feeling less controlled by the trauma, the next step is really this integration. And this is a very intense step, and it has a lot to do with that personal narrative work we talked about later. And this is really finding meaning in the experience. Why did this happen to me? And this is a question that really just sticks with me, because I think it's such a powerful piece, especially from people coming from a faith background. The question of, why did God let this happen to me? Why did my mom and dad let this happen to me, or do this to me, or not stop this? Where were the police, or why did the police do this and allow this to happen to me? There's a lot of real tough questions that go along with trauma. And to some extent, we have to start to find answers to these questions. Trauma has to become an integrated part of our story. Again, how we want it to be is like, I know a lot of you can resonate, that's a hell I've been through. I'm stronger today because I overcame that. Again, so many of our people are still stuck there. And again, we want to help folks see themselves not as victims, but as heroes. I love it. I don't get this opportunity very much, but several times a year I get to present the hero's journey to people in services, patients and clients, and boy, do they love the hero's journey. I know some of the people that follow me on my blog have implemented this in their group work. And when folks see themselves, and what I see when I do this work is that there's this amazing point where folks realize that they're not bad people. That their struggles are struggles because of their past trauma, not because they're inherently bad. And I just, how freeing that must feel. I get people giving me that feedback after attending or hearing me talk about the hero's journey, and it's just such a cool thing to hear back is, boy, I get that I'm not a bad person. And again, for some folks, it's the first time they've really thought that about themselves. Also, there's a real strategy and a lot of work being done around personal narratives as well. And a lot of the best practices coming up pay a lot of attention to this aspect of the healing process. One of the powerful things is being able to tell your story, to give voice to your story. And I think probably being in this field, if you've been in this field for more than a couple months, you've got to hear somebody tell their story and how powerful that is. So part of the personal narrative work is to give somebody a voice and a way to tell their story. Now, just a word of caution, not everybody's going to want to verbally tell their story. We know that language, putting the experience into language, is really hard for some folks. Especially, I found this in adolescence, but I've also found this throughout the life. One of the things when I go into a program, when I've been hired into a program like a residential treatment program or a school program, one of the things I start to look for right away is maybe music therapists and art therapists, but alternative ways for people to tell their story. So again, this doesn't always, and sometimes isn't good to always be a verbal recounting of the story, but a way to express the self. So helping somebody be able to tell their story, again, this can be really intense therapeutic work. But why we do this is that once I'm able to put my experience into language, I sort of take the pen back from the trauma. And instead of trauma, instead of my struggles and those challenges and my suffering, writing the next chapter, I can start to write my next chapter. And there's a really cool thing as we see this integrated into a lot of the trauma-specific treatments where we can help people really start to write the next chapter of their story, which can be really a powerful and amazing thing to hear. One more time here is that maintain that safety piece. This is a lot of hard work. And so I always like to say is if you're in a integrated care system, so maybe they're getting mental health, medical services, and case management, the team approach, and again, we want to respect confidentiality for sure, but we all want to be paying attention to safety. Even if somebody's making great clinical progress, I know that, we know a lot of people when they start to recover from depression is when they're at the highest risk for suicide. So we want to be careful throughout this. Even though they may be making progress, we want to always be on that look for safety. The final step here is post-traumatic growth, and this is really, again, starting to write that new chapter and being able to express that hope, really celebrate those success, making sure that, again, this connects with safety as well, helping people prevent future trauma. One of the really good ways to look at this is working with victims of domestic violence, and they've gone through this post-traumatic growth process. They're feeling good about themselves. They're ready to take over their stories, and now they're ready to date again. Well, they may have never been, a lot of the folks I've worked with, never been in a healthy relationship. So they're learning, they're almost going on their first date when they go back into the dating pool, and if we're not careful, they can easily fall back into past patterns. So just making sure that we're all paying attention to that is critical. And again, the goal is to really come back wiser and stronger from the experience. So again, the amazing thing about human beings and those that walk through our door every day is that if we can find the capacity and the strength to really find the person in the pain, the suffering, and all the labels, if we can combine that support with resources where they can start to transform their life, giving them the ability and the space to really tell their story and then to start to tell and write their next chapter, anybody, and I think we've all seen this, even people in the darkest places can really take control of their life and, again, get back into that life that they want to live. And it's just such a powerful, cool thing to be a part of, and the fact that this is what we do every day. Sometimes I know within the midst of it, it doesn't seem like the best job in the world, but the fact that we get to play this key role in that recovery process, to me, is just a tremendous opportunity and a privilege. I'm right at the hour mark. So if you have any questions, please type them in. But before we open them up to questions, I just want to thank everybody. I know some people might have to cut out at some point before the very end, but just want to thank the National Healthcare for the Homeless Council for, again, focusing their capacity and attention on this such important topic. I want to thank you all for your time. And, again, keep an eye out for those emails that I know they're going to publish these all online. And again, I hope these can be a good resource for you and your organization, and maybe, again, that challenge to look at yourselves as advocates within the community. So with that, I'll open it up to see if we have any questions.
Hey, Matt, at this time, we do not have any questions. Is there anything you'd like to expand on to give folks a few more minutes to enter their questions into the chat box?
Absolutely. I can always talk a little bit more. So, the piece that I just want to build on that aspect that I mentioned of mindfulness. And when we talk about the transformational process, we're really talking about helping people find and regain control of their experience. And one of the things that I see is this reestablishing that sense of I have control over my actions. And again, when we see ourselves as being unsafe in the world, when we see ourselves as lacking that control to regulate the energy and information that we're bringing into the world, mindfulness can be a huge, huge aspect of that, because mindfulness for me is sort of a twofold equation. One is the capacity building of mindfulness, and this is sort of what we've traditionally thought as meditation, yoga, mindful prayer. You can really connect this with any of the faith traditions that somebody might have. But I know with my own practice, when I started to really take mindfulness seriously, what I was able to do when I just sat and took deep breaths, because that's basically all I did at the beginning, I started to create a sense of peace within myself. And the key thing, especially for folks that are struggling so much, that small sense of peace within themselves is sort of an island of regulation. And that's where that hope can sort of stem from. Now, I think my experience is relative to so many folks I've worked with and that have integrated mindfulness into their own lives is once I was able to strengthen that place of peace and calm within myself, then when I got in stressful situations, I could take a deep breath and the peace of my practice would come into my present moment. So really from a biological perspective, what we see again is when we're taking those deep breaths and just focusing on the breathing or focusing, we're counting our breaths, is that we're taking the activation away from that amygdala. We're building that high road capacity that sends information in our prefrontal cortex. And what we're building is the ability to regulate ourselves emotionally. I can't wait for 5 to 10 years from now because I think that we're going to see a lot of, whether it's a healthcare for the homeless clinic, psychiatric wards, all these pieces, what I see more and more of is things like yoga classes being offered. And we see this huge impact of these mindfulness practices. And again, when we build that capacity within us, the other side of mindfulness is we start to catch ourselves when our own cup starts to fill up. And this is where I see it being such a powerful coping tool as well, is that if I have language to say, okay, I'm feeling stressed out, mindfulness will allow me to catch myself before I get into that crisis mode and hopefully avoid some of those behaviors that can get us in trouble. Do we have any questions?
We do. Thank you, Matt.
All
Thank you for
right.
allowing that extra time. So our first question is, what do you do when a patient or client isn't being given access to see his or her psychiatrist, and many times the psychiatrist has rescheduled the appointments?
Hopefully you can correct the situation if possible. You know, the hardest thing for me to kind of just breathe through and be okay with is when somebody says they're ready for something and then for whatever reason there's something goes wrong with that service, because a lot of times somebody has worked sometimes for years to get them that appointment set. So if that happens, I would just be as supportive as possible around that. You know, to say, you know, I know this has to be frustrating. Again, we don't want to throw other, you know, providers under the bus by any extent, but just to empathize with somebody, to say, hey, I know you were going to take a risk here and go talk to somebody, and this really, I'm as frustrated as you are about this. Let's give it another shot, and to really try to put a positive spin as possible on it. And if this is a systematic thing, I would also talk to the provider as well to say, hey, you know, I've tried to work really hard to get this person to come see you. Is there a way we can avoid this in the future? Because, again, one of the things that I've come to realize, especially when we talk about folks that have experienced severe trauma and homelessness, is that sometimes we only get one shot. And because I've seen too many people, you know, they're ready, but unfortunately their case manager's burned out, or they have a bad interaction in the waiting room, and they walk out, and they don't go back because they need one more bad experience to reinforce that the system's really not here to help me. And that's where my heart breaks, because sometimes I know if we miss that opportunity, we might not get another one. And that's what really breaks my heart around those issues. But that's a really good question, and one of my things that have really been a burnout struggle for me over the years.
Thank you, Matt. I think that balance between providing empathy while still advocating for the best quality of care for your client is something that a lot of our network has struggled with.
Yes, absolutely.
Another question we have is, do you have any recommendations for how to design the physical space of offices, lobbies, and common areas in a trauma-informed way?
You know, yes, I have some thoughts on that. And, you know, we could probably do a whole training on this topic. So there's a couple of things. So when we talk about, you know, healthcare for the homeless environments, I always, when I do the de-escalation training that I've done at a few conferences over the years, you know, there's this opportunity with HCH providers that I think really exemplifies the struggle is, and I think this will probably hit home for some people, and I don't take a side on this, but I think it's good just to put forth the challenge is, because I know a lot of people struggle with this concretely, is whether or not we put up the thick glass between the patient and the receptionist or the intake folks. Do we put up the glass? And that just shows the difficulty of creating safety in these environments, because on one hand, I would say absolutely not, because, you know, and I use an example that I experienced in my own self is, you know, I go to the Bank of the West, not to promote them or anything, but that's my bank that I use. And when I go to it in the wealthy community of Boulder, Colorado, it's just this wide open floor plan. Like there's nothing to stop me from going behind the counter where all the money is held. Now, I'm sure there's a button to alert somebody that I'm behind there or something, but really it's like, hey, just go wherever you want to. This is an open place, and I feel very safe in that environment. Now, when I go down onto Colfax, which is sort of known as kind of the rough area of Denver at times in different spots, and I go in the branch down there, there's this really thick bulletproof glass between me and the teller, and there's a guy at the door with a gun. And, you know, I will admit that I feel a lot more safe in Boulder in that environment than in Colfax, because the guy with the gun is there for a reason. The glass is there for a reason. And so here's our challenge. And to me, it's the fact that we ask the questions that are important, because I think if we take the time and are mindful to ourselves, we usually come up with the right answer is, on one hand, I need the staff to feel safe themselves. If the staff don't feel safe, the clients won't feel safe. So my number one priority is staff safety, because again, our clients can sense if the staff are afraid, then immediately the clients and patients will also feel that fear and know something is wrong. On the other hand, the challenge is somebody walks in and they have to sit behind glass to have a human interaction. They're going to feel that, and they're going to feel that message that we don't know if you're safe or not. And so this is the real struggle when we talk about becoming trauma-informed. And it's a balance of these two things. I think what I love about the HCH environment is that most people do ask these questions. One of the things working with a lot of clinics is the role of security. And more those folks are at my trainings as well, that they're not just sort of this outside contractor that comes in a different T-shirt and keeps the peace, is that they're being trained in therapeutic approaches like MI and therapeutic communication. So one of the challenges that I have is to really, when you walk into your organization, and do this not like in the beginning of the day when there's nobody there, but try if you can to just kind of walk through in the eyes of your patients and see, okay, how does the waiting room feel? Does this feel like a safe place? Do I feel welcomed here? Pay attention to some of the interactions at the front desk. Is this the kind of reception that you would want for a family member who might be coming here to seek services? What's the check-in process? What's the wait time? And then, you know, as we go back, I always think about office setup. I never like anything between me and the client that I'm working with. I like to have that open space for communication. But I'll be very honest, as working with populations that get violent from time to time, I'm the one always sitting next to the door. That's strategic, is, you know, I'm not going to get trapped if somebody gets re-traumatized. Again, I know that might not be anything about me, but they're in that mode where now I'm the abuser, and so that violence can be directed to me. So really thinking through this. With medical examinations, I always like to have people think about, you know, just slowing down enough to say, is it okay if I shut the door? And maybe you'll have to shut the door eventually, but can you keep it cracked a little bit? Or maybe for some examinations you can keep it open to some extent. I know there's so many complex issues that go along to any answer, but just really slowing down and taking an hour or so, maybe with a coworker if you can find that kind of time, and just go through and say, what's this experience like for somebody who's had trauma, and then look at your own environment as much as possible as well and see if you can get any answers to that too.
That was quite the comprehensive answer. Thanks, Matt.
I have a lot to say on that question. Sorry about that.
I know. No, it's great. It's great, and we appreciate your time. We do have a couple more for you.
Great.
What is your advice on practices wanting to have a more team approach to trauma, but they're stopped by regulations related to their scope of practice?
My easy answer, I'll try to be more succinct on this one so we can get to all questions. My quick answer is motivational interviewing, and that seems to be my fallback for most things. Motivational interviewing, if practiced within the spirit of MI, which gives you a philosophical foundation in which to implement motivational interviewing and helping people make hard changes, really gives you a trauma-informed best practice to implement across different professions. I love to train front desk people in MI. I love to teach security, therapists, nurses. I want everybody to know the language of change, because that's what we're in the business in for so many of our folks. And so I would, whether it's MI or you go with a different approach that can be trained across different provider categories, make sure you establish that common language, because I think integrated care is as much about language as it is of how we do services. If I get a total different style of communication from my case manager as I do my nurse practitioner, these mixed messages might not resonate with me. If I'm hearing this common language around cognitive dissonance, reasons for changing, motivation, these sort of things, I believe it can bring that integration to a whole different level and really provide a framework where providers can communicate across professional jargon and those boundaries. So again, motivational interviewing, it just works. I love it, and I've seen it be very effective to really address that issue.
Thank you. A couple more for you.
All right.
This person's organization has affordable senior housing where they are implementing a waitlist preference for those experiencing homelessness. How would you recommend navigating the building community response to a formerly homeless individual joining the community? For example, residents gossiping or having negative assumptions about the formerly homeless tenant.
Boy, you guys never give me easy questions. That is a really good one. I always like to say, think about confidentiality. That will give you some guidance on what you can and cannot talk about, and that could be from state regulations to what your organization has as well. So you want to make sure that as much as you can, you don't make the problem worse by sharing too much and then making the person kind of send the person up to feel isolated and different from the beginning. Beyond that, as that is kind of the preference, if people are struggling with somebody who may have experienced homelessness coming in, really, I always like to make it explicit and talk about any of those challenges. You might also, a way to do this that might be somewhat strategic and get you to the same outcome is talking to folks about creating healthy communities. And this is just a good practice for all human beings. My wife does this with her first graders as well, and I do this with people and organizations. And so really talking about how can we be welcoming to new folks. Can they be connected to maybe mentors, not the right word, but can they kind of partner up with somebody who's been in the program for a while, and somebody you strategically picked because A, that they're treated with respect by the community, and that they would be open to working with this person and really setting that up. I look at it in much the same way as bringing somebody new into any community. So maybe at the group level, talking a little bit about the health of the community. What do we want? How do we want to welcome new folks into our community? And you can be kind of open about, hey, there's folks that are going to come in that haven't really had stable housing, and what do you think they might need to feel welcomed in our community? You may not say Bob's coming on Tuesday and he hasn't experienced any of this, but just kind of getting that conversation going within the community itself as much as possible. And then I've just always seen the positive benefits if you can find the right person to be a mentor or whatever you would call that role, to really connect them with somebody from the get-go who has some buy-in to their success in the community and can kind of be their sounding board as well. Those are things that I've used effectively in residential situations, whether it's working with adults or children.
That was great. Thank you. The next one is more of a question for comment. This person says, our providers are often very reluctant to offer benzodiazepines or stimulants to many of the patients who struggle with addictions, but patients have often learned, either rightly or wrongly, that these medications are needed. So just as please comment, do you have any strategies about how to handle these perceptions or these relationships with the patients and providers? That's one that's what might work for client or patient A might not work for client or patient B. If there's some organizational hesitation around it, I would have that conversation. I always like to bring things to the surface.
So if there's a struggle, why is there a struggle? What have been some negative consequences from this? And I like to do this, and I imagine that's out there, and I haven't, nothing's fresh in my head, so I'm speaking not from a position that I know this is out there, but I'm sure it is. There's probably some scientific literature out there to either justify or contradict some of these approaches. So whenever I feel sort of this conflict of, okay, what should we do around what is a very sensitive issue with folks experiencing addiction is, what does the literature say? And let's not put judgment on that literature. Let's have maybe one or two people go do a little research and just present it back in an objective way, and then have that help guide the conversation. And then what I would hope is that there could be a very well-regulated conversation around that. Again, I think when patients kind of come in seeking or hoping for that puts us in such a difficult position too. So really recognizing the intensity around this issue of, some people probably think this is beneficial and helpful. Other people think this is probably the worst thing we could possibly do for folks. But creating a safe place within the clinic or the culture of the organization to really have a regulated conversation around this, look at research, and then always understand that there's going to be exceptions to the rules. And again, this might work for 1 out of 10 clients, this approach, but understand that this is why it's being done. So again, if we can have those conversations as much as possible, I always like them to be informed conversations because they're just about our emotional response. We don't always get a good direction on answers to the questions, so really paying attention to the emotional response, but also bringing the literature around it and kind of having a very goal-oriented conversation while giving people space to voice any frustration they might be feeling.
That's great. Thank you. Our final question, how does a client get further help with anxiety without the use of medication?
Great question. So one thing that as part of that post-traumatic growth experience for some people, medication's okay. I think we had this discussion last week as well. If somebody's struggling from an anxiety disorder and that's a chemical thing going on, medication, I always like to say medication and mental health treatment, that we want to sort of strive for that if possible, is not to say, I'm not one that says medication doesn't have its place. So, if somebody's struggling from anxiety, medication might be part of the solution. In an ideal world, and I kind of chuckle at this because this is what my middle-class friends do here in Denver, is when we get anxious or we get burned out or we get all overstimulated about something like the election that's happening next week, we go up to the mountains for a yoga retreat. So I would love to offer these same services to our folks as well. Like, why can't they go up to the mountains and just get away for a while? I think, I have this therapeutic model called a spa day for folks because I think some folks just need to check out. So on one hand, I'd love to say, hey, instead of medication for anxiety, just do yoga and mindfulness and this, that, and the other. But for some of our folks, they're so hyper-aroused because of their past trauma that what I see medication can help with is it helps lower that. It opens up their window of tolerance to maybe close to a normal level. But again, that medication, again, I like to think about as the scaffolding to build the house around, because we want to provide, if we do the medication route, really provide other strategies where the medication isn't a long-term, seen as the long-term solution. But how do we build around that, take advantage of what the medication's doing, but also then within that context, can they see a cognitive behavioral therapist around their anxiety? Can they do things like yoga classes? Can they find, I've seen health clinics that have workout rooms. I just about lost my mind when I saw it. It was the most beautiful thing ever. But they had their patients who are experiencing homeless got to go work out and then go take a shower. You know, are there other ways, and I know that's not possible for everybody, but are there other ways we can help them manage their anxiety you know, with their medications as well? If this is somebody who just can't take medications whatsoever, then those basic coping skills, taking a deep breath, working on that thing. Again, I'd love to get this person up to a retreat in the mountains, but I know, unfortunately, in our society, that's very unlikely to do. So, again, let's for a lot of folks, medication is going to be part of the solution, but let's make sure that, again, we're taking advantage of what the medication is doing in a positive way so we can, again, build that scaffolding up. But that's a really great question.
Thank you, Matt, and thank you, everybody, for joining us today. This is the end of the webinar, as we have no more questions. A link to the archived webinar and PowerPoint slides will be emailed to everyone within a few days. Any questions that the presenter was unable to respond to will be addressed via email if possible. At the close of this webinar, an online survey to evaluate it will automatically open in your web browser. Please complete it to help us improve your webinar experience. The meeting will now be closed. Thank you.